Welcome to This Week in Family Medicine. This week we are covering 6 notable papers spanning chronic disease and mental health complexity, respiratory care and infection tracking, and the clinical challenges of primary care referrals and prescribing. Let us dive in. We begin with the intricate intersection of mental health and chronic physical illness, a daily reality in primary care. A major international study published in BMC Primary Care utilized data from the first cycle of the Organization for Economic Cooperation and Development, patient-reported indicator surveys, analyzing over 100,000 primary care patients aged 45 and older across 19 countries. The researchers grouped patients into 5 mutually exclusive multimorbidity profiles to understand how combinations of chronic conditions affect physical health, mental health, and overall well-being. They discovered that profiles including mental health conditions were consistently associated with much poorer outcomes. Specifically, compared to patients with only cardiometabolic conditions, physical health scores were significantly lower among patients with cardiometabolic, mental, and other conditions, with a coefficient of -2.07, and lower for those with mental and other-only profiles, with a coefficient of -2.94. Well-being was also substantially poorer, with the steepest declines observed in patients who had both cardiometabolic and mental health conditions, showing a coefficient of -12.65, and those with a combination of cardiometabolic, mental, and other conditions at -12.08. Interestingly, while patient-reported person-centeredness in care was associated with better health outcomes overall, it did not meaningfully modify the relationship between these multimorbidity profiles and health outcomes, and continuity of care showed overall limited effects. This underlines a critical need for health systems to move beyond standard disease-specific pathways and invest in integrated, person-centered primary care models that systematically address mental health alongside physical comorbidities. This systemic complexity is further illustrated by a qualitative study, which explored the practical and logistical challenges general practitioners face when diagnosing depression and providing initial support. Through semi-structured interviews with 10 general practitioners across Scotland, the northeast of England, and Northern Ireland, the researchers identified 3 primary challenges: the clinical complexity of how depression presents, severe constraints on time and appointment access, and the erosion of continuity of care. The participating clinicians emphasize that diagnostic uncertainty is often compounded by these external, structural pressures, rather than just clinical ambiguity. Together, these 2 studies highlight that managing mental health in primary care, whether as a primary diagnosis or as a complicating factor in multimorbidity, demands not only clinical acumen, but also structural support, adequate consultation time, and systems designed to facilitate continuous, integrated patient relationships. Next, we turn to respiratory health and the management of acute and chronic infections in the community. In BMC Primary Care, a qualitative study investigated the barriers and facilitators to prescribing and adopting anti-inflammatory maintenance and reliever therapy, known as MART, for adult asthma. Despite strong guideline recommendations from bodies like the Global Initiative for Asthma endorsing combined inhaled corticosteroid and formoterol as the preferred reliever, uptake in the United Kingdom has remained low. By interviewing primary care practitioners and patients from practices that participated in a program to reduce short-acting beta-agonist overuse, the researchers identified key factors influencing implementation. On the practitioner side, facilitators included strong clinical knowledge, refined asthma management skills, and supportive practice prescribing and appointment systems. However, clinicians faced barriers such as limited resources, treatment disruptions following emergency hospital presentations, and the challenge of managing patient-specific obstacles. For patients, the barriers were deeply psychological, including a strong emotional dependence on their quick-relief short-acting beta-agonist inhalers, a fear of discontinuing them, a lack of understanding of why they should switch to maintenance and reliever therapy, and a reluctance to change due to fears of being unable to secure a timely appointment if their asthma worsened. To successfully transition patients to this safer, guideline-recommended regimen, clinicians must actively address these psychological dependencies and clearly explain the physiological rationale of anti-inflammatory reliever therapy. Meanwhile, managing acute respiratory infections remains one of the most frequent tasks in primary care, though a new study from Norway suggests we only see the tip of the iceberg. This cross-sectional study surveyed adults to track the incidence of self-reported infections, doctor visits, antibiotic use, and work absenteeism over a 3-month period. Nearly 75% of respondents reported experiencing an infection, with respiratory tract infections being the most common, affecting nearly 64% of the cohort. Within this group, approximately half reported a common cold, nearly a third suffered from an influenza-like illness, and about 18% contracted COVID-19. Crucially, only about 1 in 5 patients with a respiratory infection actually visited a general practitioner. Bronchitis and pneumonia were the most likely to prompt a clinical visit, occurring in over half of those cases, and also resulted in the highest rate of antibiotic prescriptions at 25%. When looking at productivity, respiratory and gastrointestinal infections had the largest impact on sickness absence, with COVID-19 representing the strongest predictor of missing work, multiplying the likelihood of absence by more than 9 times. This highlights that while the vast majority of respiratory infections are self-managed at home without clinical intervention, their collective societal and economic impact through absenteeism remains profound. Our final theme focuses on optimizing clinical decision-making, both in prescribing new therapies and in communicating through specialist referrals. In the Scandinavian Journal of Primary Healthcare, researchers explored how primary care physicians in Sweden perceive and experience the pharmacological treatment of obesity. Through 11 in-depth interviews, the study found that while new anti-obesity medications are highly valued as tools to initiate person-centered discussions and support weight loss, they also introduce significant clinical uncertainty. Physicians expressed concerns regarding the complexity of obesity, a lack of clinical consensus on classification and treatment pathways, unclear guidelines on the necessary duration of therapy, and substantial economic barriers for patients. The multifactorial nature of obesity raised difficult questions about where clinical responsibility lies and how limited primary care resources should be allocated. The authors conclude that clear national guidelines and a shared clinical understanding of obesity are urgently needed to reduce this uncertainty and support primary care clinicians in utilizing these medications effectively. Effective communication is equally vital when referring patients to secondary care, as demonstrated by a retrospective study in BMC Primary Care that examined how general practitioner referral letters predict triage outcomes for patients with dysphonia. When general practitioners refer patients with voice disorders to specialist ear, nose, and throat departments, triaging clinicians must decide whether to route them to a speech-language pathologist or an ear, nose, and throat surgeon and assign a priority level. In a review of 150 voice-disordered adults, the study revealed that female gender, a history of smoking, and current smoking significantly predicted being triaged directly to the ear, nose, and throat pathway and being categorized as high priority, as did a history of previous thyroid surgery. However, there was no significant association between the specific voice symptoms documented in the referral and the final triage decisions. Alarmingly, a quarter of the referral letters completely omitted critical lifestyle information regarding smoking and alcohol consumption. This omission directly hinders the triage process, suggesting that general practitioners can significantly improve the accuracy and speed of specialist triaging by consistently documenting key lifestyle risk factors rather than focusing solely on symptom descriptions. If you only have time for one paper this week, make it the qualitative study on the barriers and facilitators to implementing maintenance and reliever therapy for asthma. This paper provides invaluable, practical insights into the psychological barriers patients face when moving away from short-acting beta agonists, giving clinicians a clear roadmap on how to communicate the benefits of combined inhalers and improve adherence to international guidelines. Here are the key takeaways from This Week in Family Medicine. First, when transitioning asthma patients to maintenance and reliever therapy, proactively address their psychological attachment to short-acting beta agonist inhalers and clearly explain the anti-inflammatory benefits of the combined regimen to overcome patient hesitation. Second, patients with multimorbidity profiles that include mental health conditions experience significantly worse physical health and well-being. Primary care systems must prioritize integrated, person-centered care models over isolated, disease-specific protocols for these complex patients. Third, the vast majority of respiratory infections are managed at home, with only about 20% of patients seeking primary care, though bronchitis and pneumonia remain the primary drivers of visits and antibiotic prescribing, and COVID-19 continues to be the leading driver of work absenteeism. Fourth, Swedish primary care physicians find new anti-obesity medications helpful for starting weight management conversations, but clinical adoption is hindered by unclear treatment durations, high costs, and a lack of consensus on clinical responsibility. Finally, when referring patients for dysphonia, prioritize documenting key risk factors such as smoking history, alcohol use, and prior thyroid surgery, rather than just describing voice symptoms, as these patient-specific variables are the primary drivers of specialist triage and prioritization. That's your roundup for This Week in Family Medicine. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.